Thank you so much for having me. So yes, as my disclaimer, I am not an intensivist by any means, but was trained in point of care ultrasound during my nephrology fellowship and have carried it over. I actually use it quite a bit when I go overseas for work over there, so we don't have access to good ultrasounds. But my hope here is to give you highlights of what you may use in the ICU and just the broad aspects that point of care ultrasound can be used for nephrology, as well as some references and resources you can access later. There we go. So the objectives, we'll go over some normal kidney ultrasound basics, talk about some abnormal kidney findings, bladder findings, talk about other aspects of nephro-POCUS that's not just kidney and bladder, but looking at fluid status and some future directions that may be coming down the line. So back to kidney basics physiology 101. We've got our kidney where the blood, unfiltered blood, comes in through the renal artery, goes to this black box of the kidney full of multiple blood vessels, thousands if not millions of blood vessels, and then it gets cleaned in there and comes out filtered through the renal vein. So let's go further. In this black box of renal blood vessels, there are literally probably millions of blood vessels that are coming in and going through the 1 million glomeruli that are in each kidney and being filtered, and then the filtered blood is leaving. And so what really is making up that single nephron? So there's, like I said, 1,000 glomeruli or 1 million glomeruli or 1 million nephrons in each kidney. That blood is coming in through the afferent arteriole into the glomerulus. That's where the workhorse of the filtration is happening. And then the clean blood is leaving through the efferent arteriole. And then you have continued absorption occurring throughout the tubules. Remember back from med school, our proximal tubule, our loop of Henle. And we're filtering in a normal functioning kidney for a child with a GFR of 120 is filtering about 150 to 170 liters of blood a day. But only 1% or less than 1% of that filtered blood and filtered ultrafiltrate is actually what's being excreted as urine. The rest is being reabsorbed through the tubules. I promise that's the end of kidney physiology, so no worries. You guys have probably had a lot of this, but just to make sure we're all on the same page with ultrasound basics, really that ultrasound probe has two functions. It's sending out sound waves and it's receiving sound waves back from objects that it's hitting. The knobs on the machine let you adjust how those sound waves are sent and how they are received for what you are viewing on your ultrasound display. The amplitude is the strength of the wave. This isn't adjustable. This really is determined by the object that is hit. If there's a strong, high amplitude object, then you're seeing it as a white image or a hyperechoic image. If it's a weak bounce back from the object, it's a small amplitude and you're seeing a dark image or hypoechoic image. The frequency you can adjust. The frequency is the number of times per second that wave is coming back to the machine. And you've got low frequency lets you penetrate deeper into the body. Higher frequency doesn't go as deep, but gives you much better resolution of what you are seeing. And so for kids and kidneys in particular, the higher frequency tends to get you good resolution. As long as they're not obese teenagers, then you may need lower frequency for those patients. Again, this is just what I said. High frequency gives you better resolution and a clearer picture, but less depth. Opposite for low frequency. The different probes for nephro-POCUS, we primarily use the convex probe for both our kidney and bladders, but there's certainly applications for using the linear to assess fluid status and your phased array for your cardiac exams. So when you're looking at a kidney ultrasound, what are you actually looking at? So this is just a diagram depicting the different parts of the kidney. You can see the renal capsule here, well delineated between the liver and the kidney itself. You've got the cortex as the first layer of the kidney, and then there should be a darker renal medulla or the pyramids there, and then you'll see the brighter calyces, which is where the urine is starting to collect and into the renal pelvis. In a normal kidney, you should not see the ureter coming off. If you see the ureter coming off, that's abnormal. Just another picture, we've got the liver there, we've got our renal capsule, our renal pyramids, again, are a little darker and that can tell you the difference in the cortical and the medullary junction. If you don't see a distinction between the cortex and the medullary, then that's where you get concerned that there's some kidney dysfunction going on. And then we've got our renal sinus and renal pelvis. So typically we think of doing our kidney ultrasound when the patient is supine. We're going to first look for the longitudinal view of the patient, longitudinal view of the kidney. We're going to go just below the ribs, really pretty far back. And ideally you want to put that probe in the 10 o'clock position for the right kidney and the 2 o'clock position for the left kidney. And that's, then you're titrating and turning that probe just to get the maximal longitudinal view. What you'll see in your formal kidney ultrasounds, they'll give you a kidney size and they'll give you a length. And with practice and time, you'll realize that's their best guess. That was the best view they could get. Your good technicians can be very consistent and very accurate. Less good technicians, you could have wide variation in what that kidney size is. And so just be cognizant of that as well when you're reading your formal kidney ultrasounds. What they're doing is they're just scanning to try to get the maximal length view, and that is what has determined the kidney length. And then once you have the longitudinal view and you've gotten your length, you'll turn your probe 90 degrees and you're looking for the middle of the pole first. And that's where you get your classic C-shaped, and you'll then scan to the superior and inferior poles, and that will help you assess for masses. And so this you can see is one of the classic C-shapes right here. You've got the pelvis here, and it really just looks like a C, and that's the middle of the pole, and then you would scan both to the superior and inferior side. So when you're interpreting your kidney ultrasound, you're looking at the size of the kidney. Like we said, the longitudinal length is the primary one you're worried about. The shape of the kidney, the echogenicity. So for most normal kidneys, they should be the same or darker compared to the liver or spleen. It's a little different in neonates that I'll talk about. And then you're looking for masses or cysts and dilatation. And primarily what you'll probably focus on in ICUs is the size of the kidney, looking for dilatation, looking for any obstructing stones, major masses that you would be able to get your consultants involved sooner rather than later. So here's just a different picture of looking at the size of the kidney. You're trying to get the longitudinal view, just the maximum view you can get to give you the longest length there. There's a few different equations and estimates out there about what is a normal length for a kidney. I tend to think of an adult kidney as 10 to 12 centimeters. A baby kidney is the same as their gestational age. So a full-term baby is roughly 4 to 4.5 centimeters. If they're a 30-weeker, their kidney length is about 3 centimeters. There's a few different nomograms out there. There's some on Google. I haven't found any that are well validated or consistently used across nephrologists or radiologists. So just kind of pick which works for you. The thing to keep in mind, though, is that the height of the child is probably more predictive of what their kidney length should be than necessarily the age of the child. Again, there's some tables out there. This was an equation I found on Google that seemed to work pretty well. The age in years times 0.6, and then you add 1 millimeter per week of gestation. So if it was a full-term kid who's now 5 years old, you would do 5 times 0.6, add 4 centimeters. So they were a full term. And so, and that can, what that helps you with, depending on where you're working and you're trying to determine if their kidney dysfunction is acute or chronic. If you've got really small shriveled up kidneys, then it's much more likely to be a chronic problem than an acute problem that you'd be able to address in the ICU. The shape of the kidney. So the normal kidney bean shape is what you're looking for. Some variations that can throw you off. So this is a normal variation, not quite a normal bean shape. You'll see these kind of lobulations here. Does anyone on the line know what normal variation this is from? No, so it can often be misled as hydronephrosis. This is a normal 2-day-old kidney. So neonates, this is just a different picture of a neonate, and this is a normal variation because the neonate kidney hasn't matured enough, their cortex hasn't developed enough, that they get these lobulations that are just normal variations. And these lobulations can persist up until about 4 to 6 months of age. The baby kidney is maturing, its GFR is maturing up until 1 year of age. There's some other variations I'll talk about, I think, in a slide or two about neonate kidney ultrasounds that are just different than adults and different than older children. And so this would be a normal kidney for a 2-day-old. Echogenicity is the other thing we're looking at. So this would be a normal echogenic kidney. It's darker than the liver. This is a child who had post-infectious GN and an AKI, and it's slightly brighter, hyperechoic compared to the liver. The echogenicity of the kidney is very non-specific. I sometimes see radiologists or even commenting on, oh, it's a hyperechoic kidney, therefore they must have this. It just means the kidney is sick and we don't really know why. All right, and so some of those neonatal differences. So the lobulations are really prominent. Because the kidney hasn't matured, the cortex is quite thin. And so the renal pyramids or the medulla might appear much larger and can certainly be misinterpreted either as scarring or as hydronephrosis, as dilated calyces, because those pyramids sometimes look really dark in a normal neonate kidney. And then that renal sinus fat that would be really helpful when you're looking for particularly the transverse view in an older child is typically not present yet in the neonates. All right, this is a stumper. This is another normal variation. Any thoughts? I won't. So this is on the left side, on the spleen. Because of how the spleen and the left kidney interact, you can sometimes see the bean shape gets mismatched and it really kind of looks like a hump. And it's called a renal hump or a dromedary hump. And those are normal variations. There's nothing pathologic with this whatsoever. This you would see in an older child or teenager. Right? All right. Now we're getting into the interactive part of this. We've got several abnormal kidney ultrasounds, and just speak up. I find I'm much more used to doing POCUS hands-on when we're able to go around and see folks, but this is to just give you some examples of some abnormal kidney ultrasounds you may find. So thoughts on this one? Yep, perfect. Multiple cysts. This was an 18-year-old who had autosomal dominant polycystic kidney disease. Thoughts on this one? They are renal calculi or kidney stones, and you can see they are bright and they've got the shadowing behind them. Here's another one with a really good depiction of the shadows that you would see. If you turn your Doppler on, you can actually get a twinkling artifact. What's happening is not that there's blood flow behind those stones, but because of the hardness of the stone, the more rough the stone is, the more you'll see this artifact. And it makes the Doppler appear as if there's very turbulent flow, but it's just an artifact from the kidney stone itself. And so you wouldn't necessarily see this twinkling artifact if it was a cyst or something else. All right, thoughts on this image? It's an angiomyolipoma. The difference here is that there's not really a shadow. There's this brighter lesion here. And honestly, I wouldn't recommend diagnosing this with POCUS. This would be something you would want to follow up with a formal renal ultrasound to really delineate this. These are seen in patients with tuberous sclerosis. But it could definitely be seen in those patients frequently. Another one. It's a renal mass. What you would see different with a hematoma is you would see bulging of the capsule, and here you kind of don't have that continuity with the capsule. If the capsule has broken and it's continuing to bleed out, it gets quite large and tends to be around either the trauma, if it was coming from a trauma, or if someone had done a kidney biopsy, it tends to be around the lower pole is where you would see the hematoma collecting. But this is a renal mass, and you see this just break in the continuity of the capsule as it's breaking through. Thoughts on this one? Certainly could be Wilms. I think this was a large renal cell carcinoma, but I think for our purposes, what you're seeing is a large renal mass that you need oncology to weigh in on, right? It's basically engulfed the entire kidney capsule. Thoughts on this image? I think what I'm hearing is a duplication, right? So this is actually a duplicated kidney. So you've got one renal pelvis here and a second renal pelvis here. You would see this in your CACET children, got abnormal, maybe coming in with a UTI, pyelonephritis type picture. They're at high risk for that. This is a duplicated kidney. Thoughts on this image? I'll help you out a little. This is the kidney, horseshoe kidney, and the transverse view. This is the spine here. These kidneys, I have seen one. They are very hard to pick up from POCUS. Just given the limited time you're typically doing it, you may need a formal renal ultrasound for it. But what you'll see is your typical place when you look for your kidney, it won't be present, and you need to go further midline. Any thoughts on this image? So this is a pretty common image you would see in a child with this disease. And it's really hazy, kind of starry-like. This is autosomal recessive polycystic kidney disease. What is happening is they're having all of these tiny cysts in the cortex, and they almost look like linear lines, linear tubular cysts that are happening. And as ultrasound technology has improved and the resolution has improved, you can really start to see this picture. And these are classic images you would see for a kid with ARPKD. Thoughts on this image? I think it appears like hydronephrosis because the medulla is darker, but what you're seeing is actually the rim of the medulla is quite hyperechoic, and that's because there's nephrocalcinosis there. So this medullary nephrocalcinosis is demarcating the medulla, and so it appears like hydronephrosis. But what you don't see that you would see with hydronephrosis is you don't see a connection to the pelvis. For reference, you can look back later. There's a bunch of different causes. What you really want to check when you see that is calcium and PTH levels and consulting nephrology. All right. So but it was a good segue to hydronephrosis. So there's a few different grading systems out there. Your radiology department may use one or the other. I've seen mixed data about which is better for you as a fellow in critical care, seeing if there's severe hydronephrosis, moderate or mild is probably more than sufficient. I tend to like the UTD classification because it gives you actual measurements of this APRD. So that's the anterior posterior renal pelvis diameter, where you're actually going to measure the distance in the renal pelvis, this diameter right here. And if it's greater than 10 millimeters, it's abnormal. And once it gets above 15 millimeters, you're looking at stage 2 or stage 3 even. Okay. And so this is grade 1 hydronephrosis. So you have that AP diameter is almost 12 millimeters. You've got central calyceal dilatation. It's not moved into the peripheral calyceals. It's just in the central calyces. Here, the peripheral calyces have started dilated in grade 2. You can see there's a large, much larger AP diameter here, about 19 millimeters. And here you see the pelvis is connected to the ureter, and this is the beginning of the proximal ureter, which you should not be able to see. And then grade 3, usually it is massive and you've lost all of your good visualization of your renal cortex. Right? Your bladder. So the bladder is often much lower than we think when we're putting an ultrasound on there. And you really got to get at the pubic bone and sometimes even be tilting it further if it's a underfilled bladder. Again, you have the patient supine. You're placing that probe just at the pubic bone. Again, it's often the flaw is that the probe is placed too superiorly to be able to see it. You want to get both transverse and longitudinal views. If you really needed to, you could calculate the bladder volume and get a post-void residual where you're looking at both the length, width, and depth. Typically, a post-void residual after they've urinated should be more than 40 or 50 milliliters. Typically, what I would imagine y'all using this for is looking for obstruction. You really should, when you're looking at the bladder, you should never be able to visualize the ureters. If you're seeing the ureters, that's concerning for obstruction as well. You may, again, more advanced, be looking at the bladder wall thickness, which can tell you in your neurogenic patients how chronic it's been going on. But that tends to be best when they have a full bladder. If they have a relatively empty bladder, the wall appears thicker than it truly is. This is just a picture of what that normal bladder should look like. So it should be this nice, big, open balloon, pretty thin wall all the way around the bladder here in the transverse view and then in the longitudinal view as well. You don't see ureters, you don't see anything else there. All right, thoughts on what this might be for the bladder? So you don't tend to see it, but it can happen. This is a stone that is blocking in the distal ureter, and it's actually protruding into the bladder wall. So it's gotten stuck right at that junction between the ureter and the bladder, and it's pushing in. You could certainly see this if they had an AKI, if they were having hematuria, and you're going to need urology to be intervening there. Thoughts on this image? Is it a functioning Foley or not? I saw a couple heads shaking. There's actually a hematoma that is developed here in the bladder that is blocking the Foley catheter. This should be your normal functioning Foley. It should be hard to find, right? If a normal functioning Foley, the bladder should be really collapsed all around it. It should be hard to find that Foley catheter. And again, this is another picture of a non-functioning Foley where the balloon is well dilated in your Foley, but your bladder is not draining. You have to be careful with bladder ultrasounds because it is quite frequently that you may have pelvic ascites that can mimic the bladder. And what you'll see with pelvic ascites is that it won't have that nice round shape that the bladder has. You'll just see these irregular pockets of fluid. And so this is a functioning Foley in a well-drained bladder, but in a patient who also had large pelvic ascites. This is for the gold star of the class. Thoughts on this one? Anyone work overseas? So in places that have burdens with schistosomiasis, they are at high risk in children and teenagers for cancer that can revolve around urogenital schistosomiasis. So these are lesions from schistosomiasis that are occurring. There's some research advances going on in NephroPOCUS. I don't know if any of y'all have heard of contrast enhanced ultrasound. It was originally designed for use in adults to determine cysts from renal masses. and to try to limit exposure to both radiation from a CT as well as the nephrotoxicity from the iodinated contrast that comes with a CT contrast study. The contrast in this is essentially microbubbles, and you inject it and then image at the same time and get really good resolution of the kidney, kind of a contrasted image of the kidney. As far as I'm aware, there is not clinical use for contrast enhanced ultrasound in POCUS, but there's certainly in the research world, this is coming down the line that they're looking at it. This study showed that you could use POCUS in real time with contrast enhanced agents to detect real-time vessel occlusion. And so in this Doppler image, it's hard to see. It looks like good blood flow going into the kidney and leaving the kidney. But here with contrast ultrasound, you can see there's good blood flow in B and C in the arterial phases. But when it should have been draining, it's blocked. It's not draining as it should. And they found there was, this was consistent with a renal vein occlusion. There's other folks looking at it to look for renal perfusion abnormalities in acute kidney injury. And here they are demarcating the large renal infarct that is occurring in this patient. And this was a pilot study where they're using it to assess just the microcirculation in the kidney with different medicines, with different blood pressure parameters, and found that it was a really good alternative to it. There's other uses for contrast enhanced ultrasound for folks to just be aware of. Some centers have started using it in place of VCUGs to look for urogenital abnormalities and flow abnormalities, because it just limits the radiation exposure to pediatric patients. And so in conclusion, I think there's a lot of different applications for nephropocus. I didn't actually able to hit on all of them, but one is just the rapid assessment of your kidney size and shape, looking for acute and chronic. Also looking for hydronephrosis, if that's present or not, looking for bladder obstructions. Fluid status is a big one as well. I think there's future advances coming down the line. I apologize, there was a question about using point-of-care ultrasound for suprapubic taps. I think is certainly a reasonable one as well. I have never trained on that. It's not something I think done by most nephrologists, but certainly, yeah, useful out there. These are two of the websites I was referring to. POCUS101.com is a general one. Nephropocus.com is primarily adult specific to nephrology. There's not a lot of pediatric nephrologists doing POCUS out there, but they've got a lot of good blogs and videos on just different nephropocus topics out there for y'all to learn more.